One of the, I think, the lessons that we as a community need to start embracing is that the patients who are getting intubated in the emergency department or the ICU are just fundamentally different from the patients who are undergoing intubation in the operating room. Rates of complications are very different. There's a 10 to 20-fold higher rate of complication in the critically ill patient getting intubated. And the procedures, while very analogous, are just not the same.
Welcome to a special breaking news edition of Critical Care Time, the podcast for everyone who cares for people with critical illness. I'm your host, Dr. Nick Mark.
And I'm your other host, Dr. Cyrus Askin. Listeners of Critical Care Time know that we love talking about airway management. We've done it a few times on this show. We talked about the device trial. That was episode 18. We also covered airways on our discussion of the physiologically difficult airway. That would be episode 11 for those of you keeping score at home. And today we are thrilled to take our audience to the bleeding edge of airway management research.
And by bleeding edge, we do not mean hemoptysis. That was episode 14. We mean that we had an opportunity to get an advanced look at the exciting results of the PREOXI Trial, published today, which compared two different strategies for preoxygenation prior to intubation. So we got an early look, but we had to keep this episode top secret until the results were published in the NEJM today and presented at a conference. Personally, I think this is one of the most impactful studies of the year, something that's already changed my practice and will hopefully change our listeners' practices as well.
And not only do we get a sneak peek here, but we are lucky to be joined by first author Dr. Kevin Gibbs, who will walk us through this study and help us understand what the results really mean for those of us that take care of critically ill patients with potentially challenging airway issues.
So Dr. Gibbs is an intensivist, an associate professor of medicine, and the director of acute care trials at the Wake Forest School of Medicine section of pulmonary critical care, allergy, and immunology. Kevin, welcome to Critical Care Time. It's a delight to have you here.
Thank you so much for inviting me. Delighted to be on Critical Care Time and happy to talk about PREOXI.
So maybe just from the start, we should talk about why did you do this study?
I think there are few situations as high risk for critical care providers as emergency tracheal intubation. Complications are very common during tracheal intubation. Up to 20% of patients experience hypoxemia, and 1 to 2% experience cardiac arrest. And preoxygenation, provision of supplemental oxygen prior to induction of anesthesia, is probably the most important intervention to reduce the risk of hypoxemia.
Awesome. Yeah, I think we can all agree that intubating these patients, particularly those that are acutely ill, critically ill, what have you, is definitely a challenging endeavor, can be a harrowing task. And we kind of covered this a little bit in our discussion of the physiologically difficult airway. One sort of recurring theme that at least I took away from it is it really is all about preparation. You're trying to, set yourself up for success. And so on this episode, we're not going to rehash all the elements of our discussion from before, but I will say that one major element of preparation as it relates to airway management is this idea of preoxygenating your patient. And the thought there is the higher you can drive up their PaO2, the more time you can generally buy yourself to establish that airway. However, the reality is practice patterns kind of vary across different institutions, different places. And so I think the nice thing about this study is it may potentially unify the approach to these airway conundrums.
I totally agree. Oxygenation is really a critical step in the preparation for intubation. For patients who are on ambient air, 80% of the air in the lungs is nitrogen, 20% is oxygen. The goal is to increase that percent of the oxygen as close to 100% as possible when you're pushing medications for intubation. The reason is that the amount of oxygen you have in your lungs when the patient goes apneic is the amount of oxygen that's going to be there for the entire procedure, and is a key determinant on developing hypoxemia and complications.
One of the challenging things here is that so much of the literature about intubating critically ill people comes from the operating room, where often people are totally healthy. They're healthy enough to have surgery in a planned, controlled manner. If something isn't optimal, they cancel the case and reschedule it. And so there are some important differences between what an OR intubation looks like and what an ED or ICU intubation looks like.
I love to hear you say that, because I think that's one of the key takeaways from the work we do in the Pragmatic Critical Care Research Group. And one of the, I think, the lessons that we as a community need to start embracing is that the patients who are getting intubated in the emergency department or the ICU are just fundamentally different from the patients who are undergoing intubation in the operating room. Rates of complications are very different. There's a 10 to 20-fold higher rate of complication in the critically ill patient getting intubated. And the procedures, while very analogous, are just not the same.
Right. A tube is going in hopefully the same place, but the methods of putting it there, the planning and the choice of drugs and lots of factors may be totally different. Completely agree. Should we get into the sort of design of the trial, like how you set this up?
Yeah, I think that's a great idea, Nick. Just one other plug. I think I'll quote the great philosopher Michael Gerard Tyson, who said, "Everyone has a plan until they get punched in the face." I think again, planning is everything. We've talked a little bit. We've alluded to this reality of 1 in every 5 patients can experience a significant desaturation during these attempts at intubation. So yeah, I think this study could be really a big deal. It certainly feeds into that idea of planning. And so yeah, Kevin, why don't you introduce the study for us?
Sure. So PREOXI is a study comparing preoxygenation with an oxygen mask, which for the study was defined as either a non-rebreather or a bag mask device without assisted ventilation, or preoxygenation with non-invasive ventilation, which was a form of positive pressure ventilation with both an expiratory pressure and an inspiratory pressure, and a set rate on the ventilator. And for the study, it was a 1-to-1 randomization of those two interventions. The goal was to preoxygenate patients for at least 3 minutes prior to induction of anesthesia. But this is a pragmatic trial, and so we only preoxygenated as long as it was safe for the patients. And then the primary outcome for the study was hypoxemia, which was defined as an oxygen saturation of less than 85%.
My kind of review of the study, and just a quick recap, is I think 17 ICUs, 7 EDs were included across the United States. So nice broad population, at least as it relates to the United States. I believe about 1,300 or so patients were enrolled, focused on patients who really needed tracheal intubation, who were among other criteria were not already on PAP of any sort. So you kind of took that out of the equation there.
Yeah, let's talk inclusion, exclusion, and then talk about who the patients were.
I think if I was trying to summarize it, the major strength of this inclusion criteria was that we were including all comers in the ED and ICU who were breathing spontaneously, so they didn't have hypopnea or apnea, and were not already on positive airway pressure at the time. So they couldn't have an LMA device in place. They could not be already on BiPAP, and they couldn't be requiring assisted ventilation using a bag mask device.
But the goal of enrolling a population which was as broadly representative as the sort of all comers we see in the ED or the ICU.
That's right. And I think when we talk about the historical context of this question, it's important to discuss the prior work that was done in this space. So 2 studies have compared non-invasive ventilation to oxygen mask preoxygenation. They were both done in France, but those studies were restricted to ICU patients with acute hypoxic respiratory failure. And so that was a very different population than what we were looking at. We were going for maximal generalizability. There was not a requirement to be hypoxic in enrollment, and it was the people we're taking care of on a day-to-day basis in the ICU who are getting intubated. We were really going for all comers.
I was going to ask you about this later, but maybe we should double click on this now. That I think there's one exclusion criteria that I saw that I think we should highlight, which is people were excluded if they had emesis, hematemesis, hemoptysis, or they were judged to be at high risk for aspiration. Is that right?
That's not entirely right. So,
okay, please.
So I think this study was pragmatic in its exclusion. So the clinicians could always opt out of enrolling someone, but there wasn't an explicit exclusion saying that patients who were high risk were excluded. So that was based on clinical judgment. And if you look back at, and we'll get into the results later, but actually 15% of the patients enrolled in the study were having a GI bleed at the time of intubation.
Okay, that's a really important point to emphasize there. So even though, basically it was the physician's judgment. Like, would it be appropriate to put BiPAP on this person if they were randomized to that arm?
Yes, that's right.
Got it.
And I think, and it was, I guess for maybe we can sort of make this conclusion our own, but unblinded study for I think fairly obvious
hard to
reasons,
blind
right?
which mask you're on.
Exactly, yeah. So that's kind of one element that should, I guess, be reiterated, but again, pretty obvious. And like you said, I think the main element of your study, or the primary endpoint, was how many folks were dropping below 85% on their SATs in the peri-intubation period. Is that correct?
That's right. So between induction of anesthesia and 2 minutes after successfully placing the breathing tube, that was the window in for looking at that. And this was a binary outcome. You either drop below 85 or you didn't.
And that's important, and maybe a little bit of a reminder to some of our audience members that have listened, that peripheral pulse oximeter is often a lagging indicator. It's going to lag more in states of shock. I think extending out your interval was pretty clever, up to 2 minutes post intubation. You might not see that desaturation right away. So I think definitely a clever consideration on y'all's behalf.
As I like to tell people, the pulse ox is a time machine. You're seeing, typically 30 seconds in the past, but if somebody's really perfusing poorly, you could be seeing a minute in the past. So sometimes you get that tube in, you're ventilating them, oxygenating them, and their sats continue to drop for like an agonizing period of time until they sort of turn the corner. So yeah, I think it's good design. So do you want to walk us through what the results were? What were your primary findings?
Yeah. So as Cyrus mentioned, we enrolled 1,301 patients in the study. The majority were in the ICU. And what we found was that preoxygenation with non-invasive ventilation reduced the rate of hypoxemia by roughly 50%. So there was an absolute risk reduction of approximately 9% between patients preoxygenated versus with oxygen mask versus those who received non-invasive ventilation.
Right. And so I think it went from 18.5% in the oxygen mask group to 9.1% in the non-invasive group, which is a huge effect size, first of all.
Right. We think we don't really anticipate seeing the effect sizes this large, but you only need to treat 11 patients with non-invasive to prevent hypoxemia. So it's a small number needed to treat.
Right. And I think you sort of sliced this a couple other ways as well as sort of, confirmatory findings, but like the number of people who had more severe desats, like below 70%, was similarly more in one group than the other. Is that right?
That's right. So we had exploratory outcomes looking at severe and very severe hypoxemia, defined as oxygen saturations less than 80% and oxygen saturations less than 70%. And non-invasive ventilation reduced the rates of severe and very severe hypoxemia. We also looked for a number of potential interactions, and so I think one of the key takeaways from the study was that non-invasive ventilation was at least numerically better in every single group we looked at. So whether the patient was in the ED or ICU, it didn't really matter. It was better, I think. And most striking to me, and I think what my personal takeaway was that it didn't even really matter how much oxygen the patient was on prior to the decision to intubate. So there was a benefit seen in patients who were on room air when the decision was made to intubate to preoxygenate with non-invasive ventilation.
I think that's a really striking finding, in fact. I mean, you don't normally see the pre-planned subgroup analysis where literally every subgroup does better with an intervention than the control.
That's right. I think, and we did look at this in pre-specified subgroups. The only subgroup where there was heterogeneity was obese populations. In fact, the magnitude of the effect of non-invasive was even larger in that population.
Makes sense.
Than it was in the population at large. But what I would say is that there was a benefit across all subgroups, which I think which is pretty important when we're talking about what the implementation is for this intervention.
Absolutely. And I think, remembering that the number needed to treat to prevent one episode of significant hypoxemia is 11, but and it may actually be even lower than that in some populations.
That's right.
Yeah. So, I mean, this is all like well and good, but I mean, what I guess a desaturation is just a desaturation event, right? Can't we just kind of bag them up and be done with it? What does it matter?
Oh, I love the leading question. It's great. But I would say two things. The first is that it's very hard to analyze what are the downstream effects of hypoxemia. I mean, clearly, no one wants to be satting 80%. It's probably not good for end organs, but that's a very hard outcome to quantify. Then there's the procedural consideration as well. It certainly seems easier to me to intubate someone when they're satting 100% than when they're satting 80%, and you're hearing the beep, boop, 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 getting lower and lower. And I think, and so just from a technical standpoint, you're much calmer. It's much easier to place the tube.
Huge point. That's like that in and of itself. I mean, that's giving me like some PTSD to some of the hairier innovations I've had. It's like, that's that comfort level that you get knowing that the patient's satting 100% and you've got time. I would totally submit to you.
In flying, they say that, altitude is time. I think in airway management, oxygenation is time. Mm-hmm. And it's a valuable resource. You want to make the most of it.
And then the other point is, and I think this is what you were alluding to, is the effect on cardiac arrest. And so if you look at the observational data sets, hypoxemia is associated with cardiac arrest and death in patients getting intubated. That's never really been demonstrated in a randomized trial. In this trial, there was an association with a reduction in cardiac arrest in patients who received non-invasive ventilation. So 7 patients in the oxygen mask group suffered cardiac arrest in the peri-intubation setting, and only 1 person in the non-invasive group did.
And I just want to emphasize that is a statistically and clinically significant difference. You could argue that transiently having a SAT of 84% may or may not matter. I think I probably had a SAT in the 80s when I was like mountain climbing in Peru, right? Because I was a nerd and I brought a pulse ox with me. But it's impossible to argue that a statistically significant number of deaths doesn't matter, right? That seems like a profoundly important finding in a prospective study.
That's right. And I think you always have to be cautious about over-interpreting exploratory outcomes. But if you look at the other clinical outcomes, although the only one that reached statistical significance was cardiac arrest and death, ventilator-free days, ICU-free days, all those, and mortality, all were numerically favoring non-invasive ventilation. And so I think it's reassuring that all the clinical indicators were going in the direction of non-invasive ventilation. It seems like we were impacting clinical outcomes.
Right. And I actually, this wouldn't be critical care time if we didn't nerd out about some physiology. So one thing I wanted to talk to you about was, why do you think non-invasive is better? Do you think it's the improved oxygenation, or do you think it's something else? Because we often worry that putting the transition from negative pressure to positive pressure in somebody who's under-resuscitated can cause hemodynamic collapse. And sometimes I think about non-invasive as sort of a trial of positive pressure and sort of an opportunity to do things like tuning vasopressors or giving volume. Do you think that was something that was going on here?
That's funny, because when we were reviewing the results for the first time, the moment we knew that we delivered an intervention was when we looked at the comparative hemodynamics of the 2 groups. Blood pressures were lower in the non-invasive ventilation group. I mean, we were delivering positive pressure to these patients. It was affecting their hemodynamics. I think my suspicion is that the difference in outcomes is not related to clinicians intervening to address potential cardiovascular collapse or anything like that. I think this is truly related to the effects of non-invasive ventilation during the preoxygenation phase. And the reason I say that are twofold. In 2019, the same group of investigators, actually, the pragmatic care group, published the PREVENT trial, which looked at comparing post-induction bag mask ventilation to essentially canonical RSI, where once you go apneic, there is maybe apneic oxygenation, but no ventilation. They found a similar reduction in hypoxemia. But in this study, we actually attempted to analyze patients based on the relative likelihood that they were going to receive positive pressure ventilation after induction. What we found was that the magnitude effect was the same regardless of the likelihood of receiving post-induction ventilation. And so whether a patient was likely to be bagged post-induction or not, that didn't change whether non-invasive was effective. It was still effective in all the patients. And when you look at the oxygen saturations, patients had higher oxygen saturations than the non-invasive ventilation group at induction compared to those in the oxygen mask group. So at all points in the procedure, oxygen saturations were higher. So I think at the end of the day, patients were going into the intubation procedure with more oxygen content in their lungs. And that's really what made the difference most likely.
So it seems to me the fundamental difference when you're giving someone positive pressure is that you're increasing their mean airway pressure. If you're giving someone 100% FiO2 and you've got a great seal without positive pressure, then theoretically you're giving them as much as enriched air as you can possibly give them. By adding the non-invasive, you're adding that pressure. Why not just be more liberal with your BVM?
Yeah, so that's an excellent question, and I want to take that. I want to take that in 2 parts. I think the first part is you're right. This is probably a mean airway pressure effect to some extent. I don't like anecdotes. I think they're generally not clinically useful. But this last week when I was on service, I had a patient who was on non-breather on top of OptiFlow, 85%. They were taking 700 cc tidal volumes We made a decision to intubate them. We transitioned them to non-invasive ventilation. They needed no IPAP. They had strong negative inspiratory pressure and high drive, but immediately with the increase in positive pressure, their sats climbed to 100. It's purely due to mean air pressure. So I think that is the physiologic mechanism in play here. I think the issue with just being liberal with bag mask devices are twofold. If you're doing them in the pre-induction phase, it's hard to sync up the bagging with the patient's inspiratory efforts, particularly if they have high drive. You're not really controlling tidal volume at all. You're not controlling inspiratory pressure as well as you would be with a non-invasive ventilator where you set the pressures. It's possible you're overdistending, you're asynchronous with the patient. So in general, I think pre-induction ventilation in patients, it's challenging. It's challenging to do optimally. There are often large leaks. I don't routinely recommend that. In terms of post-induction positive pressure ventilation, many of the sites who participated in the study actually participated in the original PREVENT study, which was looking at post-induction ventilation. Despite that, only a minority of patients in the oxygen mask groups received post-induction ventilation. And I think that goes to show the difficulty of implementing routine post-induction ventilation. The nice thing about non-invasive preoxygenation is that you set up the ventilator, you set up a respiratory rate and inspiratory and expiratory pressure, and the ventilator will deliver post-induction positive pressure ventilation. You don't have to change anything else. You're set for the entire procedure. It's one and done.
And it kind of eliminates, I guess, that operator characteristic of like people bag differently, they bag with different rates, they bag inconsistently. You're really taking that out of the equation.
That's right. And if you look at clinical practice, at least prior to the study, globally, non-breathers were the routine device used. So you're in a situation where you need a second device to deliver positive pressure if you choose to go down there.
Makes sense. And I think one other benefit to emphasize, which maybe is not captured in the study, but I think a good thing to emphasize to our listeners, is just that you also have a great rescue device too. If you fitted them for a mask, you've sized it appropriately, and then you're having trouble intubating and you need to recover them, it's very easy to recover them on non-invasive once the mask is already there and ready.
That's a good point. That's something I personally have never tried. But
oh, really? So if you've had trouble on first attempt, you've bagged them in between, or?
Yeah. So I personally, in that setting, would transition to either an LMA device or if I was not confident that I could subsequently intubate them, or I would bag mask device for reoxygenation.
Interesting. Yeah. See, I've both. And what I love about using the non-invasive mask is it just gets a better seal than even a pretty good operator with a BVM. And as you said, it delivers consistent ventilation. There's less of the like panicked giant breaths.
Before we started this work, I think the one thing that I was not appreciative of how important the seal is. The seal is everything when it comes to oxygenation. I think this has mostly been studied in the ED context and also mostly in healthy volunteers. But often I think people, connect their bag mask device, crank up the FiO2, feel like, okay, I'm delivering 100%. But the moment you start training ambient air into what the person is breathing, your oxygen saturations drop down to potentially as low as 50%. It's really important. If you're using
you may be oxygenating their beard at 100%, right? Their lungs not so much.
Yeah, and I didn't appreciate how important really an ideal seal is, and how important technique is when you're using a bag mask device. Non-invasive really eliminates a lot of the technique issues.
Yeah, well said. Maybe we should talk about the converse of this, though, which is, the potential downside of a tight-fitting mask, I guess, which is like the risk of aspiration. The classic point is that, you have to be very cautious with non-invasive in people who might aspirate, but that's not at all what your studies seem to find.
That's right. So I would say a couple of points on this. I would actually argue that we don't really understand what the risk factors are for aspiration and intubation. It makes intuitive sense that positive pressure ventilation after induction is a key risk factor. But the two largest studies to look at this are PREOXI and PREVENT. And in both of those studies, there was no association between aspiration and positive pressure ventilation, and we looked at that in a number of ways. We looked at that as operator-reported aspiration. We looked at it as new infiltrates on chest X-ray as read by a radiologist who was unaware of the study. And there was just no signal there. There are a couple possibilities. There's a possibility that positive pressure is not with either a bag mask device or, in this case, a non-invasive ventilator is not really associated with an increased risk of aspiration. Or if it is, the risk is so small that we were unable to detect it. In which case, benefits of non-invasive preoxygenation outweigh that. Theoretically, when you're using a non-invasive ventilator, you can set the inspiratory pressure below the opening pressure of the lower esophageal sphincter, and so potentially that risk is further reduced with non-invasive ventilation. But I think my major take-home is that there hasn't been an association with positive pressure ventilation after induction and aspiration in randomized trials.
And in your study, there were numerically more people with aspiration in the oxygen mask group than in the non-invasive group.
That's right. Now, if I was criticizing my study, I would say, well, the exclusions for the study were altered mental status. Clinician identified risk of aspiration, and those were key exclusions. But if you think back to all the critical care that we've delivered over years, all the interventions we've done, there are just not that many interventions where the clinicians are experts at predicting an outcome like aspiration. I think it's highly unlikely that clinicians were successfully excluding all the patients at the highest risk of aspiration.
That's a great point, and I think that this is one of many factors that goes into aspiration risk. I think, having a prolonged intubation attempt, having unsuccessful attempts, also things that you can control beforehand, like positioning them, having the head elevated, using gravity to maintain gastric contents in the stomach. Like, there's a lot of other things that you can optimize. Yeah. This is just one variable. And the data, at least as far as these two big RCTs, suggests that aspiration is not truly much higher in selected patients.
We talked a lot about how the idea is that you're giving yourself more time to safely intubate a patient. You're increasing their PaO2. You're using pressure. You're using FiO2 to achieve that. And I think we can all agree that that's a good feeling. Like, we like to see that 100% on the monitor. Well, look, I'm the Tom Brady. I'm the Michael Jordan. I'm the Tiger Woods of intubation. So what does it matter? Like, I can get the job done real quick anyway. So am I really going to get a benefit from this if I'm really that good or think that I'm that good?
Yeah, I
think that last part's the key part, right? The difference between are good and think good.
Right.
Yeah. Two things. There was a very real risk of hypoxemia in the patients who were on room air at the time of the decision to intubate. And I think most of the doctors going into those airways were pretty confident that their patients were not going to get hypoxemic. They were on room air. In these patients, most of these patients received high quality preoxygenation with either an oxygen mask device or a non-invasive ventilation. So not only was the patient not on oxygen prior to intubation, but the clinicians made a concerted effort to preoxygenate this patient, preoxygenate the patients prior to initiating intubation. So I just don't think we are able to predict the physiologically difficult airway as well or as robustly as we think we can. And then perhaps we all overestimate our procedural skill to some extent.
And I think actually to double click on that point too, I mean, let's talk about the interaction between the pre-oxygenation method and operator experience. So I think looking at your supplement, your typical operator was a EM or critical care resident or fellow who'd done about 50 intubations. Is that right? That is what we saw in the study, and that's actually what we've seen in the other studies as well. Do you think that this is applicable to somebody who's done much more than that?
That was the criticism that we received for device, right? Is that, that the difference between video and direct may be dependent on operator skill. I would say that none of the analyses for that study supported that notion, particularly that video was superior regardless of operator skill. Likewise, I just think that, even if your anticipated duration of intubation is going to be 40 seconds versus a minute and 30 because you're so good, but your patient's going to be starting at a higher oxygen saturation if you start with non-invasive preoxygenation. So your stats can be 95 versus 92. I just think I don't think that there is a substantial interaction between skill and this intervention.
Yeah, I share that. And actually in our episode talking about the device trial, we had a similar takeaway, which is that yes, there may be more benefit for less experienced operators, but that doesn't mean that there isn't still a significant benefit for experienced operators. To use that aviation analogy that I like so much about how like oxygenation is altitude, who wouldn't want more altitude to troubleshoot a problem? Right.
And that's kind of gets to what I was kind of joking about is like, if you think you're God's gift to the endotracheal tube, do you really need this? And I would argue, I tell this to my residents,
anecdotally, that is a risk factor for difficult airways.
I agree, but absolutely, and I would say like I tell my residents this all the time, like you don't get doctor points for making your life harder. You don't get doctor points for creating a more challenging situation, for forcing a bad position on yourself. And so I guess my takeaway is like, why not put in the time and effort, the modicum of time and effort to effectively pre-oxygenate your patient, which I think is what this study is sort of suggesting, right?
Yeah. I tell our fellows overnight this all the time. And, our fellows are in-house. Many of them have hundreds of intubations to their credit. Many of them are very good airway operators. But I tell them, there is evidence that the risks of emergency tracheal intubation are reduced in the context of having two experienced operators at the bedside. And so, during the daytime, you have your attending physician there to back you up, and we're there largely for moral support. But overnight, I would encourage you to call the anesthesia airway team to back you up, because even though I'm very confident in your abilities to do this, having a second operator at the bedside has been shown to be helpful in keeping people safe. I think delivering high quality preoxygenation is important to keeping people safe.
It's this idea of checking your ego at the door. I think we thought that was like a recurring theme this season on Critical Care Time. Is like, yes, we get it. You're good enough. You can almost certainly do this on your own in the middle of a desert with no one around you.
Whittling in a tracheal tube out of bamboo. Yeah.
Right. But just because you can, should you? And like, it's important to be confident in your skills and your ability to get the job done. But I think especially if it's a high risk situation and you have resources available, if there is a bad outcome, that's a bitter pill to swallow, I think, if you didn't utilize those resources that you had within arm's reach.
Right. They're just not 2-minute procedures that we do that have a 1% to 2% risk of death. And this is one of them. And doing the best we can is important.
I would argue that every intubation we perform in the ED or ICU is a difficult intubation. Things are not set up for you optimally, whether you're talking about the room and the equipment, or like the person is not fasted before, or maybe they're not, perfectly optimized before. Like, take every advantage you can, because you already have several big disadvantages.
I want to talk more about the equipment in a little bit, but I did want to bring up something that Nick mentioned earlier. And I think it's this concept of who is non-invasive safe for. And I think it's really important to think about how we're using non-invasive for preoxygenation versus destination non-invasive therapy. In destination non-invasive therapy, where my goal is to avoid intubation, I would never deliver non-invasive ventilation to someone who has copious secretions, someone who's obtunded, someone who's requiring restraints. These are all relatively hard contraindications for me, because I think at that point, there's risk of something untoward happening and having a massive aspiration event if they, for instance, throw up into their mask. But when you're doing 3 to 5 minutes of directly observed non-invasive therapy, I'm very comfortable having someone who's obtunded on non-invasive ventilation. The contraindications that we think of for non-invasive ventilation don't really apply to a situation where you're going to be at the patient's bedside the entire time, or you're going to have a nurse at the patient's bedside the entire time while you're gathering supplies.
That is so, I love that you said that, Kevin, because like, it's another thing that I often teach my residents is like, yeah, there's a huge difference. It's not subtle. There's like a Great Wall of China's difference between like slapping someone on non-invasive who's like got a GCS of 9 to 9.5 on a medicine ward where you're not going to see that patient for another couple hours, versus in the ICU when I'm the person putting the mask on them. And I'm the one that's like watching.
I've got the yank hour in one hand. Right. I'm at their head. I'm talking them through what's happening. Yeah.
It hugely different. I mean, I would say it changes the dogma, but it doesn't really change it's a different situation entirely. And so I'm really glad you brought that up. Totally agree with you.
Thank you for making that point. I think that you said that really well, and I think that's a really key takeaway. I have two follow-up questions for you on that. So first of all, I've had this happen before. This is like a humbling experience where you put non-invasive on somebody with an intent to intubate them. Like, put non-invasive on, I'm drawing up meds, I'm getting my equipment ready, I'm like getting to the head of the bed, I'm doing all this stuff, and the person just like perks up and does miraculously well. Then you're in this situation where it's like, well, I probably wouldn't have used non-invasive on this person otherwise. Like, I was committed to intubating them, but now they're doing so well. Is that something, first of all, is that something you saw in your study? Is there like a intention to treat versus as treated? And second, what would you do in that situation, I guess?
Good questions. So patient was enrolled not at the time when they received non-invasive ventilation, but it was when enrollment was someone who was intubated or attempted to be intubated. So
you've already made the decision to intubate.
That's right. So if you made the decision to intubate and you put non-invasive ventilation on them and you decide, hey, this person's now doing Sudoku, they don't need to be intubated. that person was not enrolled in the study. It didn't affect the outcomes. So this was an intent to treat, but only in patients where there was an attempt to intubate the patient. So I think it's totally reasonable in terms of the study, that did not affect the interpretation.
Essentially, your intention to treat and your as treated were the same.
For the most part, yes. I generally agree with that statement. There were a couple crossovers, but that was not. But we didn't. Everyone who was randomized and got intubated was included in the analysis. And then in terms of my personal practice, I think it largely depends on the context. And this did happen in the study. There was a patient. There was at least one. I think there were maybe more. There was a patient who was primary indication was altered mental status. They got randomized, then they woke up between randomization and intubation. The clinical team decided, hey, this person no longer meets indications for intubation. They were not intubated. It's totally fine. And that's doing no harm to the patient. In my practice, I think if someone was being intubated for altered mental status and woke up, I would not intubate them. I'd struggle much more with someone who's had like ARDS as an indication for intubation. And I think this is beyond the scope of this podcast, but it's not entirely clear to me what the role is of non-invasive ventilation patients with primarily acute hypoxic respiratory failure due to ARDS. I would say that I am comparatively conservative to some people in my practice in terms of managing people on non-invasive. I think someone who's requiring positive pressure in the context of ARDS should probably be intubated. But I'd love to see more data on that.
Yeah, there's like one or two really intriguing studies, but I think, drawing vast conclusions from half-vast studies is always dangerous. And there was that really exciting JAMA paper about helmet non-invasive ventilation in patients with ARDS, but haven't seen it replicated. I want to believe, but I agree with you.
Well, there was also, I think, one of the branches of the recovery trial during the pandemic looked at kind of like timing of intubation and use of non-invasive and maybe added a little bit of wind beneath those wings. But
I think my big takeaway is that, in that setting, you're using non-invasive to sort of control the circumstances of intubation a little better, to sort of make it a little safer, a little easier, a little bit more controlled. But I'm very skeptical that those patients with ARDS, you're going to ultimately not intubate them if you use non-invasive. Like, I think it doesn't really avert intubations.
That's a dream. It would be disease, or it'd be syndrome modifying in that case, I guess. But I think that's so. In general, it would take. I have a pretty high bar for having me aboard an intubation for hypoxic respiratory failure, is what I would say.
Yeah, that's a good point. I mean, I think I've had one or two of those, like somebody who you go to intubate because of obtundation, and then they sort of wake up, and whether that's like all the stimulation of 10 people in their room getting ready to intubate them, or whether it's other things that you happen to be doing at the same time, like you gave them dextrose, you gave them Narcan, something else. I've seen that a couple of times, and I don't know whether to credit the non-invasive or the everything else,
But I have another question, kind of getting us back to maybe the decisions as far as putting the study together. I think the results of the study are compelling. And later on, I think we can talk about, is this practice changing? Is it not practice changing? Is this practice affirming? That sort of thing. But right now, I'm kind of thinking back, when I was doing my my fellowship, it was really like the height of the COVID-19 pandemic and heated, humidified, high flow nasal cannula was sort of this darling that was becoming very commonplace in our ICUs as sort of like a trial of oxygenation. You get maybe a little bit of positive pressure, although the extent to which you're getting positive pressure out of that, I think, is going to vary a lot from patient to patient, situation to situation. But I noticed that high flow was not mentioned in this study. And so I was curious if there was any thought put into like having a third arm where you were using high flow as your pre-oxygenation strategy, or what are your thoughts on the role of high flow in these types of situations?
Yeah, I definitely need to caveat the statement because I'm gonna sound high flow skeptical, which I'm not. I think in general clinical practice, you're gonna have to pry the OptiFlow out of my cold dead hands as I try to administer it to all my patients. I love high flow nasal cannula. I think high flow nasal cannula were practice changing for me, and they're the cornerstone of my management of hypoxic respiratory failure. The official line of the study is that this study allowed high flow nasal cannula in both arms, and it was at the discretion of the clinicians. But the study was not designed to detect a difference in that, and it cannot inform the use of high flow nasal cannula as a pre-oxygenation strategy. On a personal level, I'm a little skeptical that high flow nasal cannula is that different from non-rebreather or a back mask device. And I think the study data to date on high flow nasal cannula as a pre-oxygenation strategy has been pretty mixed. And so although I would love to see robust data on its use, this study is not informative. It's not really designed to do so. I would say that a couple other points on that issue, though, is that the use of high flow nasal cannula in general practice for pre-oxygenation is pretty rare. If you look at the Intube study that was published in JAMA in 2021, and this was different time. But what they found was that only 1% of patients worldwide were getting high flow nasal cannula as a pre-oxygenation strategy. Secondly, it requires another device to be in the room, right? So you're setting up for intubation. You have your ventilator, you have your video scope, you have your bag mask device as a backup, and then you have to have this awkward pole with the heater and the humidifier. It's just another thing to have set up at the time.
And often you're limited in how many oxygen ports you have in the room, or how many spigots you have, right? Yep. Yes. And that's the next question I wanted to ask you, because I noticed in your trial, you actually, for each center, you list like what the equipment they had was, right? And for like 2/3 of them, it was a dedicated non-invasive machine. But right. Increasingly, and as a selling point for some ventilators, they sell invasive ventilators that can also provide non-invasive ventilation.
So I haven't done a survey of all the ventilators, but most modern ventilators are capable of delivering non-invasive ventilation. And certainly in my institution, we've worked with both Draegers and Servos, and both of those were capable of delivering non-invasive ventilation. And at my center, we routinely encouraged people to use the ventilator that they were going to have the patient on after they were intubated for the pre-oxygenation. I think that has substantial feasibility implications because there are real concerns about having to have the respiratory therapist set up and break down a brand new device, use it for 5 minutes, break it down, then connect them to an invasive mechanical ventilator, right? There are costs associated, there's usage, there's respiratory therapist and clinician effort involved in that. This study demonstrated that was feasible. Actually, 70% of the patients in the study had that done. But there may be some long-term implementation effects from that. It's much easier to say, this is the ventilator we're going to use in this patient for the foreseeable future. All we need is a mask. We're going to connect a mask to this ventilator, pre-oxygenate them with that, leave the mask in the room for when they're extubated, and we're just going to go through the ventricular tube and we're going to connect them to the same ventilator. That's our practice currently, and I think that's the way to do it.
Yeah, I think so too, and I think that assuming this does change our practices, and I hope it will, that this will become a much more standard way of pre-oxygenating people. That seems like a more elegant way of doing it, where you bring one device into the room, you hook one thing up, you just bring another mask, in addition to your intubation supplies. I think practically that's a lower barred implementation. And I'm imagining, especially in like smaller emergency departments, where they maybe have like limited number of machines, and the idea of taking like the one non-invasive machine out of service to clean it after using it for 5 minutes, that may seem like a showstopper. Conversely, using one machine for both seems like a really elegant way to solve the problem.
Yeah,
Nice.
I personally think that's the major advantage compared to high flow nasal cannula. And so I think in this very specific context, and again, our study doesn't inform this, but high flow nasal cannula may have some benefits in terms of apneic oxygenation. You can leave it on the patient during the entire procedure, but that's pretty speculative. It's not really supported by robust clinical trials evidence that it's better. And it's just, there are real implementation challenges to that. So that's why I think that's one of the strengths of non-invasive.
Just to amplify that point, looking at the supplement now, I can see that something like 10% of patients in the oxygen mask group were also getting high flow nasal cannula during laryngoscopy. And despite that, there was still more hypoxia in that group.
Good point. So, I think that's a great discussion. Nick, I wanted to kind of get to that fundamental question of practice changing, practice affirming. How do we kind of look at this, kind of the 50,000 foot view? But before I did you have any other specific questions before I kind of get into that?
No, I think I've tortured Kevin enough with all the subgroup analyses, and your supplement S33 figure says this. So no, let's talk about the big question, which is, what does it take for a groundbreaking study to change our practice?
Yeah, I think it's a great question, Nick. And so as I was kind of reviewing this, I said, okay, well, again, our approach, I think, to many things in life are sort of like aimed by our prior experiences, by our mentors, et cetera, et cetera. So for me, I had this kind of like my formative years in the ICU were during the COVID-19 pandemic. And so the idea of using non-invasive as a pre-oxygenation strategy was something we were just kind of doing, maybe not with intention. A lot of times it was like out of reluctance to intubate someone for fear that they're going to die on the ventilator, right? But in practice, what functionally happened was we would be pre-oxygenating them more or less with non-invasive, and then doing these, possibly crash intubations, maybe not crash intubations, what have you. So all of that is to say, for me, I find that pre-oxygenation with non-invasive in an ICU setting is pretty, is not terribly novel, somewhat common, at least in my practice settings. But where I do feel like this is truly practice changing would be in the emergency department, where to me, this is not as commonly done. And perhaps this is the fuel for the fire that motivates that change in that pre-ICU setting. Obviously, we saw great results on both sides of the house, which is fantastic. But that's kind of my takeaway. It's like practice affirming in the ICU, at least for me. Practice changing, perhaps, in the emergency department.
Yeah, I think that's a good point. And I need to be a little cautious here because I'm not an emergency medicine doctor, and so I really don't want to overstep on that. I'd like to think that this study does two things. Number one, demonstrates that delivering non-invasive ventilation, positive pressure ventilation during induction in the emergency department is safe. Mm-hmm. And that was not a given going into the study. And number two is that although patients in the emergency department are likely at lower risk for hypoxemia than those in the ICU, hypoxemia still occurs in that patient population. Delivering the best quality preoxygenation is important. And so I think there is a role in the emergency department. Prior to conducting this study, at least in the ICU population, some critical care societies recommended using non-invasive ventilation for preoxygenation, either in patients with acute hypoxemia or potentially in all comers. Despite that, the overwhelming majority of patients in the world were still getting preoxygenation with an oxygen mask device. And I think the reasons for that were because of the quality of the data supporting those recommendations was insufficient. There were two studies, one was positive, one was negative. I think this is a practice-changing study. It's the largest study of preoxygenation to date. It is associated both with a positive primary outcome and with a reduction in cardiac arrest and death. I just think that although there are some implementation barriers to overcome in terms of training and equipment, it's globally pretty feasible. I hope that this is widely adopted.
I agree with everything you just said, Kevin. I think this is truly a practice changing study. They don't come along that often, and this is one of them. So congratulations, first of all. Thank you for doing this work. I think just to emphasize a couple of points you said, like, the prior studies were like 300 patients, and this is, as you said, 1,301 patients. This is a much bigger study that demonstrates with strong power what the benefit is. There's not going to be a bigger study than this. So it's not like we can wait for another trial, right? I think like this is the definitive trial. And I think importantly for implementation, this is not a matter of you have to go out and buy something new. You have to get some fancy new expensive piece of equipment that's going to gather dust most of the time. This is basically use the resources you already have in a slightly different way, which is provably better. And I think that's a good recipe for implementation. I think the key is disseminating this knowledge. So thank you for coming on the podcast and helping us do that.
Again, Kevin, I thank you so much for giving us this opportunity to present this on Critical Care Time. This was a great discussion, both about approach to these patients and safely caring for them from a physiology standpoint, from a general kind of preparedness standpoint, and then obviously spending quite a while, I think, talking about the nuts and bolts of your study. I do think that by and large, this is going to be practice changing. I think one of the problems I run into, I need to remember that we're not all in the community. We're not all academic intensivist tertiary or quaternary centers. And so for folks that are maybe working out in the community who aren't as familiar with using non-invasive in this way, this is absolutely a big friggin' deal. So thank you and your group for this incredible work.
Thank you. Thank you for having me. It was a lot of fun.
I think we look forward to seeing more from you guys and having more discussions like this. Very excited. Obviously, we never shy away from airway issues on Critical Care Time.
Yeah.
And we definitely want you guys to check out this article. It is in the New England Journal of Medicine. It's a huge, I think, landmark study as far as airway operators go. And we will have some show notes for you on criticalcaretime.com.
And we'll link to the article too. So for people who come to our website, you can read the show notes. You can link to the article. While you're there, you can subscribe to our mailing list or leave us a comment too if you like. Yeah. So thank you very much, Kevin, for joining us. This has been great. While we're on the subject of saying thanks, let's say thanks to our listeners too. Listeners who have made our show as popular as it has been, especially the ones who have left us comments or especially 5-star review comments. Thank you all very much.
Yes, shameless pandering to our audience. Please keep sending those our way. And we obviously would like to keep hearing from you guys via X at Critical Care Time. At Crit Care Time, or you could reach us directly at Nick M. Mark or at Askins_Razor. We're on Instagram, we're on Threads, we're on YouTube, we're all over the place.
Kevin, do you have a website or social media channels or something you want to plug here?
Yeah, I'm pretty passive on Twitter at Kevin Gibbs MD. I very much regret having the MD in my Twitter handle. I think I'm also. I think I'm on Blue Sky as well, although I'm also pretty passive there. I think I'm AutoPeep on Blue Sky.
Oh, that's a good one.
Yeah.
Yes. Yeah. That's going to give Nick a run for his money on the Peloton with Krebs cycling.
That's right.
Oh, I like that. And then I just wanted to, the Pragmatic Critical Care Research Group has a website which has current and future studies that our network is doing, and I think it's exciting, interesting work. Finally, I think it's also worth mentioning that the U.S. Department of Defense was the funding agency for this trial, and they were excellent partners in our work. And I think it's nice to have a clear pathway to funding these important emergency tracheal intubation studies, and so that was essential.
Big thanks to DoD for making this possible.
Yeah,
absolutely. Excellent.
Well, thank you. Thanks, both.
We should probably thank our sponsor as well at this point.
Yes.
Our episode, like all of season 1, is sponsored by C-Star Medical. We are grateful that C-Star Medical has sponsored Critical Care Time. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. You can check out their website, cstarmedical.com. That's SEASTAR medical.com. Before we go, we'd also like to thank the other incredible members of our podcast team, our production company over at Podpaste, Kurt Belknap, who composed the theme music you're probably hearing over us right now. Lastly, we'll just hit you with the usual disclaimers that this podcast and all related media is property of Critical Care Time. You're welcome to share the content, but please acknowledge your source.
And as always, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only, so if you have actual questions for an actual physician that you might work with or what have you, maybe direct them there and don't just listen to our podcast.
Right. Like if you're using this like as a step-by-step guide to intubate somebody right now, that's not the right way to listen to this podcast.
Yeah, I think there are fellowships for that sort of thing. But in any event, thank you guys so much for listening, and thank you again for your support. Thank you, Kevin, for coming on and talking to us about PREOXI. I'm Dr. Cyrus Askin. So long.
And I'm Dr. Mark. Thanks for listening.